Well, thank you for the kind words, and I apologize for not having been here earlier, but I was actually trying to take care of patients. So I actually modified the topic a little bit because I would actually challenge that most of these small molecules are actually chemotherapy. So I'm going to modify it a little bit. Is cytotoxic chemo-free treatment a reality in follicular lymphoma, indolent NHL, and Waldenström's? These are my conflicts. So what am I going to talk about? I'm going to talk about antibody-directed therapy. That's clearly chemo-free, cytotoxic chemo-free. I'm going to talk about immunomodulatory drugs, targeted pathway inhibitors, immunotherapy. That's all okay. I'm not going to talk about nonspecific cytotoxic chemotherapy. That's not going to be any mention. Studies that include small molecules and cytotoxics, they're gone. I'm not going to talk about immunochemotherapy, and I'm actually not going to talk about immunoconjugates, even though they're near and dear to my heart, because immunoconjugates, antibody drug conjugates are chemotherapy. So how are we going to approach this? We want to target the lymphoma, so we have to target the tumor cells and the place where they live, and that's the microenvironment. We have to recognize that tumor cells live within a microenvironment, and we have to be able to figure out how to manipulate that. But fundamentally, we want to target the tumor cell. So if we want to target the tumor cell, we have lots of options of molecules that are uniquely expressed on B cells. Obviously, the granddaddy of them all is CD20, pretty much put to, I think, put in the genome by God as a tease. Can we find something that will actually revolutionize the treatment of B-cell lymphoma? Because you take CD20 out of a mouse, and it's completely fine. So it's actually a non-essential gene that has fundamentally changed our treatment of disease, but there are lots of other targets. We could target the cell surface immunoglobulin itself, and Dave Maloney and I did a lot of this in Ron Levy's lab, but there are other cell surface molecules that are appropriate to target. We can target pathways. We can target the B-cell receptor pathway or other pathways within the cell. And we can actually target the microenvironment itself. T regulatory cells are important negative regulators of the immune response. We also have important checkpoints, and you heard a lot about checkpoint inhibitors in the talk on Hodgkin lymphoma. And there are actually a whole range of targets on T cells that can activate T cells and overcome T cell inhibition by the tumor. So if Rituximab is a good starting place, we should start with Rituximab. This is an important trial. This was the SAKK trial. Patients received 4 doses of weekly Rituximab. Patients who were responding went on to be randomized to either maintenance or observation. The important point here is that single-agent Rituximab was highly effective, that giving some extended dosing improved event-free survival, and in fact, in long-term follow-up, and I point out that these are really different scales here. The scale, oops, let's get away from that. The scale here is in months, the scale here is in years. There is an overall survival advantage for the extended dosing in this study. That led to, well, if 4 doses was good, maybe 5 years is better. So the standard arm in this study was the 4 weekly weeks of induction, followed by 1 dose every other month for 4 doses, versus 1 dose every other month for 5 years. If we look at the number of patients, there was 261 patients. The complete response rate was actually relatively modest, 13%, with a CRU rate of another 3%. So most of the patients achieved a partial response in this study. However, event-free and progression-free survival were actually favorable, interestingly, in the primary analysis, and that is the one shown on top, the event-free survival, it's actually not statistically significantly different. So 4 doses of extended dosing were as good as the 5 years of dosing. Progression-free survival, interestingly, was in favor of the long-term extended dosing. So why was it? Well, there were a number of events, and some of the events occurred early in the long-term dosing arm, suggesting that there was a bias against dosing. So when this is reanalyzed with a methodology that emphasizes late events and de-emphasizes early events, which is a little bit odd, it is statistically significant for event-free survival. But importantly, with long-term follow-up, it's hard to put a piece of paper between those overall survival curves. So the overall survival has not been impacted this is in follicular lymphoma. Hypogammaglobulinemia, though, is a problem. We originally reported this, and then this prospective SAKK trial has confirmed these observations. The drop of IgG to less than 5 gram per liter, which in our parlance would be 500 milligrams per deciliter, is about 1/5 of the patients with short-term maintenance, but don't take pictures, I'll give you the slides. And 40% with long-term maintenance. But interestingly, if you follow these patients over time, and this is the same exact observation that we made, is that if you wait long enough, a lot of people become hypogammaglobulinemic, and many of these patients develop what we termed symptomatic hypogammaglobulinemia, and that is hypogammaglobulinemia with recurrent sinopulmonary infections requiring antibiotics and resulting in the administration of intravenous immunoglobulin. Another approach was performed by the ECOG in the RESORT trial. They also started with 4 doses of rituximab and then randomized patients to either receive rituximab maintenance, a different schedule, 1 dose every 12 weeks, versus retreatment at progression. And the primary endpoint was time to rituximab failure, that is, when you stop responding to rituximab. And again, the response rates were really quite similar to the SAKK trial, but the time to treatment failure was identical for maintenance or retreatment. However, for maintenance, you got that result with 16 doses of drug at about $12,000 a dose versus 4.5 doses of drug at $12,000 a dose. So it seems that retreatment is an appropriate way to go. Well, what about other indolent lymphomas? Marginal zone lymphoma is a complex disease. We have splenic marginal zone lymphoma, nodal marginal zone lymphoma, and extranodal marginal zone lymphoma as the major subtypes of lymphoma. However, there are significant overlaps between these entities. Single-agent rituximab has been shown in splenic marginal zone lymphoma to be highly effective with excellent progression-free survival and also with quite good results in extranodal marginal zone lymphoma, at least of gastric type. Interestingly, there's actually very little data on single-agent rituximab in nodal marginal zone lymphoma because it's an extremely rare entity and it's hard to actually do such a study. What about rituximab in Waldenström's? Well, rituximab in Waldenström's, single agent was done in 69 patients. Response rate a little bit lower than we see with marginal zone and with follicular lymphoma, and with a PR rate, a traditional PR rate of only 27%, but in the Waldenström's world, responses include minor responses, so the overall response rate was 52%. Median duration of response, however, was a little bit better than 2 years. but caution, with single-agent rituximab, there is frequently a flare in about half of the patients where the IgM level can rise and can rise very abruptly, and it's very essential to monitor these patients, and they may need plasmapheresis for symptomatic hyperviscosity syndrome. So can we improve upon rituximab with antibody doublets? Well, we tried this in the CALGB. I'm going to pretty much sum this up as no. The overall response rates were a little bit higher, but if you look at the progression-free survival, the SAKK trial, remember, progression-free survival was about 3.5 years. Well, here's the progression-free survival is about 3.5 years. So antibody doublets, at least with Ibrutinib, anti-CD20 antibody, and Glucosamab, an anti-CD80 antibody, were not the answer. Well, can we make rituximab better? Well, one of the ways we can make rituximab better is to combine with an immunomodulatory drug, and we have heard about lenalidomide. Lenalidomide is really quite pleiotropic. As Anita mentioned, it binds to the cereblon protein in the E3 ubiquitin ligase cascade, and it alters the metabolism of Icarius zinc fingers 1 and 3. As a result, it has a wide range of effects. It can improve the synapse between T cells and tumor cells, and thereby improve direct killing. It augments the activity of effector cells, particularly NK cells, to perform ADCC. It allows enhanced direct NK killing by NK cells. And there are some microenvironment changes, which are probably more important in multiple myeloma than they are in indolent NHL. CALGB 5401 was a 3-arm study, and I will take blame for this 3-arm study. This was for relapsed refractory lymphoma, and I insisted that we have this rituximab arm because rituximab, by the time this study was launched, was a standard first-line treatment. So we didn't actually know what single-agent rituximab would do in the relapse setting. And this study was open for a year, and like 7 patients went on. It was open for 18 months, and 9 patients went on. And then we decided to close this arm, and in about a year, we finished the study. So sometimes the right scientifically study is not what, and you have to actually design your studies in ways that can be accomplished and can complete the study. But we did get valuable information from this, and we actually confirmed the hypothesis that addition of lenalidomide to rituximab would enhance activity. The overall response rate did increase by about 20%, but importantly, the complete response rate doubled to nearly 40% in the combination in the relapse refractory setting, with improvements in progression-free survival. The overall survival difference is not statistically significant, though this is a woefully underpowered study for overall survival. So lenalidomide and rituximab was moved to the upfront setting, and Nathan Fowler led this study at the MD Anderson. Even though patients theoretically could be treated for 12 months, actually turns out 90% of patients on this study were only treated for 6 months because they achieved a complete response prior to that and did not need the 1 year of treatment. The treatment looked at both at all 3, follicular lymphoma, small lymphocytic lymphoma, and marginal zone lymphoma. And the results were really quite impressive. The small lymphocytic lymphoma overall response rate of 80%. Remember that single-agent rituximab in small lymphocytic lymphoma is around a 20 to 30% drug, so this is pretty impressive. But if you look at marginal zone lymphoma, we're talking about a 90% response rate with nearly 70% complete responses, and in follicular lymphoma, a 98% response rate with nearly 90% complete responses. Well, the criticism is it's MD Anderson, it's a single-center trial. Is this the real world? So the And here are the PFS curves, and you can see overall survival is excellent, and these responses are durable except in small lymphocytic lymphoma. So we wanted to know in the real world, can this be done? So the Alliance had 50803, which was essentially the same study, but for whatever reason, we had to give the rituximab on a different schedule. We gave 4 induction doses and then 1 dose every other month. But essentially, it was the same regimen, and we got essentially the same results. Remember, we saw a 98% overall response rate. Well, I would argue that in a multi-center trial, 98% versus 93% is pretty darn close. And I would actually argue that a complete response rate of 72% in a multi-center trial where a whole bunch of bone marrow biopsies to confirm CR weren't done is really actually a pretty remarkable result, confirming the MD Anderson result. What about pathway inhibitors? PI3 kinase, as I mentioned in my comments, is involved not just in the B-cell receptor, but it's downstream of multiple critical B-cell pathways, including CXCR4, CXCR5. It's downstream of IL-6, CD40, as well as the B-cell receptor. So Idelalisib has been studied for indolent NHL in a so-called double refractory population. What is double refractory? Double refractory means they either did not respond or progressed within 6 months of of both rituximab and an alkylator. There are 125 patients in this single-arm study. Patients were treated with Idelalisib 150 milligrams twice daily, and these patients were all relapse refractory patients. The median age was 64. You can see there's a distribution of histologies. And if we look at the results, about half of the patients with follicular lymphoma responded, 61% of small lymphocytic lymphoma. Well, that's not surprising. We know that this is active in CLL. But about half of the patients with marginal zone lymphoma, and among the Waldenströms, 80% responded. Now, it's only 10 patients, and this is one of the major problems. But the benefit occurred in most patients, even though only 57% met formal response, and the median progression-free survival was about a year. BTK, likewise, is downstream of multiple pathways. It's downstream of the toll-like receptor. It's downstream of CXCR4, CXCR5. It's also downstream of the B-cell receptor. And in different diseases, I would posit that different of these pathways are critical in the activity of BTK inhibitors. BTK inhibitors have been studied in follicular lymphoma in the relapsed refractory setting, 36 patients in a study led by Nancy Bartlett, where the results were actually quite disappointing. Only 28% of patients responded. And this was a little bit surprising because in the phase 1 study, there was a suggestion of a substantial activity in follicular lymphoma. One of the interesting things that deserves much more investigation is in Rituxan refractory patients, the response rate was awful, was only 6%, and why that happened and what was special about these patients is just unknown. But but overall, the progression-free survival was acceptable, despite the low overall response rate, you can see the waterfall plots here. What about Ibrutinib in Waldenström's? Well, this was the pivotal study, 63 patients with Waldenström's, and they received 420 milligrams of Ibrutinib daily. The response was extremely high, with no CRs, but 10 very good PRs and 36 PRs and 11 MRs. Adenopathy resolved in 68% of patients, splenomegaly in 57% of patients, and if you look at the Waldenström's International Prognostic Score, it actually did correlate with response. These responses are quite durable. Progression-free survival is really excellent. Why is there a difference between progression-free survival and event-free survival is because Ibrutinib, though a well-tolerated drug, is not taking atorvastatin. These are drugs that still have side effects, and the difference between these curves are patients who come off for adverse events. But overall, the overall survival has been excellent. So marginal zone lymphoma, I suggest that you stay tuned to ASH, where you'll see the study of Ibrutinib in marginal zone lymphoma. You've already heard some of this data from John, so I'm going to do this very quickly. But venetoclax is a second-generation inhibitor of the BCL2 family. Navitoclax was the first generation. It inhibited both BCL-XL and BCL2. But that caused unacceptable thrombocytopenia, which was an on-target effect. Venetoclax is a re-engineered molecule that really specifically displaces SH3 peptides from BCL2 and not BCL-XL. So this is a cartoon of how it works. There are pro-apoptotic proteins and anti-apoptotic proteins, but to be a really true pro-apoptotic protein, you have to be activated by a BH3 peptide, which are tightly bound to BCL2 or other BCL2 family, anti-apoptotic family members. Venetoclax specifically displaces these peptides from BCL2 rather than from BCL-XL or MCL1, and allows them to bind to BAX and BAC and result in induction of apoptosis. So I'm sure John went over the dose-limiting toxicity of this agent in mantle cell lymphoma and CLL was tumor lysis. It resulted in a alteration in the ramp-up schedule. And in NHL, you can see the ramp-up schedule there. In Waldenström's and CLL, the ramp-up schedule is below. This is a modestly active single agent in follicular lymphoma, though it is actually does appear to modulate chemoimmunotherapy, though I promised I wasn't going to show that data, so I'm not going to. But again, we have interesting tidbits and suggestions that these are good drugs in Waldenström's and marginal zone, but with 4 and 3 patients respectively, I would argue we need a lot more patients. So what about checkpoint inhibition? You've heard a lot about it, so I'm not going to tell you why. Follicular lymphoma was studied in the broad nivolumab study, and the overall response rate was 40%. 4 of the 10 patients had objective responses. A word of caution, don't do this at home. These are chemo-free. Well, they're not toxicity-free. And there have emerged unexpected toxicities of novel combinations. SAKK Idelalisib was a phase 1 for CLL and indolent NHL, and actually the Jonathan Friedberg was involved in this study, and the study had to be terminated early, secondary to development of severe pneumonitis in 14% of the patients. The onset was late, and the suggestion was that this was immune-mediated. Rituximab-lenalidomide Idelalisib was actually studied in 3 separate studies, 2 in the CALGB and 1 at the MD Anderson, including indolent NHL and mantle cell lymphoma patients. And this had to be terminated secondary to severe hepatotoxicity or a cytokine release type syndrome. And then finally, rituximab-lenalidomide and Ibrutinib was a phase 1 study in first-line follicular, resulting in rash in 73% of patients, 32% grade 3. Look up the CTCAE. Grade 3 rash is really nasty. Here, allopurinol may have been a complicating factor, but again, a significant augmentation of unexpected toxicities. So these probably are resulting from on-target effects, but they may also be resulting from off-target effects, or they may be what I call on-target effects for off-target things like the T regulatory cell. They are hitting the correct pathways in the T regulatory cell, but it's just that we don't want to hit the Tregs. So future directions, unequivocally, anti-CD20 has changed the natural history of follicular lymphoma and probably splenic marginal zone lymphoma and extranodal marginal zone lymphoma. Less clear whether it's fundamentally changed the natural history of Waldenström's. I think that we can credit Ibrutinib with. The targeted therapy has variable activity in indolent NHL. We need to include adequate numbers of patients of various histologies to really determine efficacy. Checkpoint inhibition may have a role, but we need further data, and there are exciting studies. Single agent activity is palliative, and we need to really focus on combination strategies, appreciating that novel combinations may have novel and unpredicted toxicities. What the goal should be is not to give a drug forever. The goal should be to really fundamentally attack the cell, eliminate it, and allow for time-limited therapy. We have to limit toxicity to the patient and financial toxicity to the system. Novel trial designs are necessary to incorporate toxicity that may develop late, and we have a number of these. And we have a whole variety, which I'm sure you've heard about during the course of the day, of combination studies that are actively enrolling at Memorial. So with that, I'll stop and take one or two questions. We're a little bit late.